to share my views about the diabetes management, and today we will be discussing the role of co-formulation in the Indian realities. What is the published evidence and what are our practical experiences as far as the usage of this insulin is concerned, and then we can have, after the end of the talk, some questions or some comments from the delegates who have joined. So all the delegates who have joined, it's my citizens. We'll be talking about the challenges that we Indians face as far as the diabetes management is concerned. And do we have in the insulin any 2:1 solution, or rather 2-in-1 solution? And what are our clinical experience if there is a 2-in-1 solution available for that? So I'll be talking about this in next 25-30 minutes, and then we can have some discussion. We very well know this study. First, on the left-hand side of the slide is the pure study where white rice intake was associated with incident diabetes in our Asian population. You can see that overall, compared to that, the Europeans, because their white rice intake is low, Africans, they also do not take that much of white rice, but compared to that, China, Southeast Asia, including Korea, Vietnam, and then the Asian countries like Pakistan, India, Sri Lanka, and Bangladesh, these four countries, because of a very high rice intake, not only carbohydrate, but amongst the carbohydrate, white rice intake, they are at increased risk of type 2 diabetes. Well, 10-15 years, we used to say that rice does not cause diabetes. Once you develop diabetes, you need to control the amount of rice. But this study done by none other than Dr. V. Mohan and his team from Chennai have shown that diabetes can also be caused by increased rice intake, especially the white rice intake. On the other hand, the right hand side shows you the START study done by Shashank Joshi and his group, and it was published about 10 years back, which also showed that not only carbohydrates are responsible for increased prevalence of diabetes, it is also responsible for high postprandial glucose in our patients. The reason being that the energy intake that we take, about 60 to 70% comes from the carbohydrate. You can see that wherever we go in India, whether we are in the west, that is Gujarat, or whether we are in the east, that is Bengal, or whether we are in the south, that is Kerala and Tamil Nadu, or whether we are in the north, that is Delhi and Punjab and the other states. Everywhere in India, it is the carbohydrate content which dominates our plate. For an example, in the west, like Gujarat and Maharashtra and Rajasthan, we take lot of rotis and rice. So our main diet is again carbohydrate based. Even in the breakfast, we start with, in Gujarat, say khakra or paratha, or sometimes bread if you are more westernized. All this contains a lot of carbohydrates. In the south, we know that it is mainly the rice items, maybe idli or dosa or uttapam or whatever. It is the rice items starting from the breakfast to the dinner contains carbohydrate. And so is the scenario in the east, where again rice remains one of the most important staple component of their diet. Even in the north, people take a lot of parathas, and the paratha, we know, it contains carbohydrates and fats and less of proteins. So wherever you go in our country, carbohydrate forms about 60 to 70% of our energy intake, and that is why it is responsible for high postprandial glucose level, which we see after all the meals in our country. And that is why right from day one, for our diabetes patient management, postprandial control becomes equally important as is the fasting glucose control. Compared to that, the Westerners have significantly high fasting, but not that much high proportionately high postprandial levels. The reason being that they eat more fat, they are more centrally and as well as overall obese, but their carbohydrate intake is not that great, and that is why they have high fasting glucose values but not very high postprandial glucose values. So the management goal in the Western countries is mainly fasting glucose control, whereas in our country it has to be fasting as well as postprandial glucose control for not only reducing the HbA1c but also to reduce the glycemic variability and also to reduce the micro as well as the macrovascular complications that are associated with diabetes. So what are the key realities of managing diabetes in our country? Well, we discussed that there is very high intake of carbohydrates for us. So there is higher glucose excursion after every meal, breakfast, lunch as well as dinner. There is high baseline PPG value in diabetes. Of fasting sugar values have almost 30 to 40 milligram per deciliter higher postprandial glucose values. For an example, for a Western patient, if the fasting is 160, their postprandial may be 180 or 190. Whereas in our country, if the fasting is 160, most of the times the postprandial is in the range of 230, 240. So there is a significant difference between fasting and postprandial, causing a lot of glycemic variability. Moreover, we initiate insulin therapy very late. We do not initiate after 2 drugs, never. We initiate after 4 or 5 drugs, after 10, 15 years of diabetes, when the beta cells have already almost exhausted. And that is why when we initiate insulin, we do not have only first phase defect, we have first phase, second phase, as well as the overall secretory defect from the beta cells, and that is responsible for very high fasting as well as very high postprandial value, about 9, 9.5. And because of this delayed initiation, when we start insulin, we need to take care of both fasting and postprandial. In such scenarios, basal insulins more often than not fail. Of course, they bring down the fasting, they bring down the HbA1c by about 1 to 1.5%, but from 9, they cannot bring it down to 7, which is our desirable target. We also need simple and convenient insulin regimen because there is an inertia to take insulin. And if we make the therapy more complicated by giving them basal-bolus or basal-plus type of therapy, the adherence rate or the acceptance rate of the patient is going to be extremely low. So we need to address this situation by choosing an insulin which will take care of fasting as well as postprandial, and that's why 2-in-1 insulin, that is what we want. In addition to the beta cell defect, we also are blessed with high waist circumference, high total and visceral fat, hyperinsulinemia, and more insulin resistance that complicates the situation that only insulin is not sufficient. We need to take care of our diabetic patients along with insulin, some of the oral agents which will also address all these scenarios. Let us talk about the 2-in-1 solution for our Indian diabetic patients. Well, 2-in-1 solution is for all the patients globally, but why it is suited to our patients that we already discussed. What is that 2-in-1 solution? The IDEC-ASP or the co-formulation, that is the only co-formulation insulin available in the market right now from Novo Nordisk. It has 2 components. There is a 70% proportion of the ultra long acting insulin degludec, and there are dihexamers or multi-hexamers of IDEC insulin, degludec insulin in the solution. At the same time, 30% of that is short-acting aspart, and there are IDEC aspart, insulin aspart hexamers. These 2 insulin components do not interact in the solution or even in the subcutaneous tissue, and that's why they retain their individual properties. Now, someone may ask that what is the difference between this insulin and the premix insulin that we use, that is human mixtard or Novomix? Well, in Novomix or human mixtard, there are 2 different insulins, but it is only the one type of insulin, that is insulin aspart. Aspart is protaminated into an intermediate acting insulin, and that is why in this solution both do not exist as separate molecules. They exist commonly, and that is why you can see that in the mixed-start cartridge or in the no mix cartridge, there are two distinct colors. One is cloudy and the other is clear. Seen, unless you mix it well, the patients are not going to get desirable effect. Compared to that, in IDEC-S, both this insulin exist absolutely differently, and that is why they do not interact in the solution, nor they interact in the subcutaneous tissues, and that's why they retain their individual properties. Whereas with mixed-start and no mix or Humalog mix, this is not true. What is the advantage of that? The advantage is that if you are giving IDEC-S, you are sure that if you are giving 20 units of IDEC-S, you are injecting 14 units of degludec insulin, and you are injecting 30%, that is 6 units of a short-acting insulin. So both this component will work separately. IDEC-S will, degludec will work for the fasting control, aspart will work for the postprandial control. So the two different insulins in one solution make it an ideal insulin to take care of both fasting as well as the postprandial glucose values. And that you can see from this graph that there is a distinct prandial and basal glucose lowering effect. This is aspart, which takes care of the prandial values, and this is degludec portion, which takes care of the fasting values, the basal component. So both these distinct effects make this insulin one of the best as far as the fasting and postprandial control is concerned. So is there an evidence or a randomized controlled trial to suggest that or to support that? Well, you can see that this trial, which was published in Diabetes, Obesity, Metabolism in 2013, where one group was assigned to IDEC-S, that is co-formulation or Ryzodec, plus the other OADs. The other group was assigned to insulin glargine, which is again a standard of care, plus OAD. The study was for 26 weeks, and it showed that with IDEC-S, there was 1.4% superior HbA1c reduction compared to insulin glargine. And similar fasting glucose control, though there was only 70% of the basal component in this IDEC-S insulin. So similar fasting control, better HbA1c control, and better postprandial control when it was given at bedtime. Yes. You can see from this slide that compared to insulin glargine, you can see that the insulin degludec, which was given at the time of the dinner, the post-dinner values that are in the blue color with IDEC-S are significantly lower compared to insulin glargine. This is baseline for both. This is after treatment. So fasting is almost same, superimposed. Postprandial breakfast is almost same. Pre-lunch is almost same. Post-lunch is almost same. Pre-dinner is almost same. The difference lies in the post-dinner values, where post-dinner values of Ryzodec are 57 milligram per deciliter lower compared to insulin glargine. And we know that uncontrolled postprandial glycemic excursions can lead to oxidative stress, endothelial dysfunction, and that's why macro as well as microvascular complications. So one of the key factors of controlling postprandial glucose is to reduce the micro and macrovascular complications in the long run by reducing the endothelial dysfunction. And you can see this significant difference in the postprandial between the two groups. So fasting equal, postprandial much better with Ryzodec, and HbA1c understandably so because the postprandial has gone down, HbA1c lower with Ryzodec. Again, in this study, 72% more patients could achieve their target without experiencing hypoglycemia. So when idea gas losing is timed with the major meal of the day, the bolus insulin component safely curbs the postprandial excursions. So you have to decide at what time you will like to start rhizodec, whether with breakfast or lunch, with dinner. It depends on two factors. One is which meal is largest for the patient. That is number one. Or second, at what meal time the glycemic excursion is highest. So you can decide based upon these two or one of these two factors at what time you will time the digestion. Usually for our patients, dinner is the heaviest meal, and that is why there is a tendency to initiate IDAGAS before dinner. But there is nothing wrong if it is initiated at breakfast if the patient is taking very high breakfast or his post breakfast values are high, which usually is the case in many of our patients. Moreover, you can also offer flexibility of changing the timing of IDAGAS. We'll come to that a little bit later. These days, everyone just does not talk about fasting, postprandial, or HbA1c control. The time in range is also a new parameter through which we can judge the overall glycemic control. And from the studies that have been done, the derived time in range of IDAGAS is much better compared to derived time in range of basal insulin. You can see here that more than 70% derived time in range, 50% of the patients in IDAGAS compared to only 34 in the glargine group. More than 70% time in range without time below range, so no hypoglycemia and most of the times under control, 43% with rhizodec, 31% with glargine, and more than 5% increase in the time in range, again better with IDAGAS. So IDAGAS was associated with significantly greater derived time in range versus glargine without an increase in time below range in insulin naive patients, and that is what the study showed. This was published in 2021. Whether switching him to IDAGAS will help? Well, switching to IDAGAS is associated with lower total and basal insulin dose requirement and significant improvement in the quality of life. You can see here that there is significant reduction in basal and total insulin dose with IDAGAS. You can see IDAGAS end of the study, the dose is compared to glargine much lower. And the therapy related quality of life questionnaire, again there is significant improvement in the quality of life score in the IDAGAS, probably because of two reasons. One is the device is much simpler and more patient friendly. And second, they are getting good postprandial control, which is very important as far as the patient understanding is concerned. If their fasting is normal but the postprandial is high, our patients are not going to be happy. If both are under control, then only they will feel that yes, they are having good control over their disease, and obviously the better quality of life associated with that. Because of several reasons, about 75% of the patients preferred rhizodec compared to the glargine treatment from which it was switched. So compared to glargine U100, IDAGAS not only gives better control, but reduction in the insulin dose also and improvement in the quality of life, and that is why the patients prefer rhizodec compared to glargine. Let us have a deep dive into the impact on the quality of life and treatment preference. Then the 94% showed that they manage their day-to-day activities better after IDAGAS penetration. About 90% said that there is improved quality of life with reduction in number of pricks, and about 86% found it comfortable to inject IDAGAS in different social situations, because you can have flexibility. If you do not want to take before dinner, you can take it before lunch also, you can take it before breakfast also. So depending upon the major meal which you are taking, you can definitely change the timing of IDAGAS, and that is not possible with glargine. So there is reduction in the number of injections, flexibility is there, and simplicity of dosing with Idegas translates into better quality of life and better preferred patient preference as far as the Rhizodec is concerned. Sorry. Okay. Moreover, in this study, there was noticeably significant reduction in the pill burden. Well, in our practice, we do not reduce the anti-diabetic pills once we start insulin. Yes, usually we cut down the dosage of sulfonylurea, but the other medicines like metformin, AGI, DPP4 inhibitors, SGLT2 are usually continued. But in this study, it was noticed that with Rhizodec, the number of OADs came down on 2 OADs 13%, on 3 OADs 47%. So number of OADs also went down with the initiation of Idegas. Now finally coming on to the clinical experience and practical recommendations about the use of Rhizodec. Well, what will be the dose at initiation? Well, some people start with higher dose, but my recommendation would be to start with only 10 units with major meal or meal with highest postprandial excursions. So start with 10 units, monitor the fasting and try to bring down fasting between 100 to 120. Till that time you increase the dose of Rhizodec. Once the fasting glucose control is achieved, also look at the postprandial breakfast, lunch and dinner, and you can modify the dose of the oral anti-diabetic agents. If the fasting is normal and the postprandial is high, you have the option of adding an AGI or maybe adding a ripaglinide-like drug or adding another insulin, that is bolus insulin or a mealtime insulin before that particular meal. One very commonly discussed option after insulin initiation is to add a GLP-1 analog which will take care of the postprandial, and I think that is a very evidence-based option because insulin along with GLP-1 will lead to reduction of the insulin dose, prevent weight gain associated with insulin, and reduction of the risk of hypoglycemia. So one can also consider GLP-1 if it is already not there on the board. What is the relation to the meal time? Well, it has to be injected 5 minutes or 15 minutes, 5 to 15 minutes before the meal with largest glycemic excursion. You can give it with breakfast, you can give it with dinner. For a person who has frequent traveling or has to attend frequent social or business meetings, you can choose the timings, different timings on different days. If he is taking the insulin daily before breakfast because his breakfast is high, but if he chooses to have large dinner tomorrow in the meeting, he can take the insulin at the dinner time. So that flexibility is offered only by this type of insulin. How to titrate? Well, the titration is classically done through the fasting glucose values and not through the postprandial glucose values. So you target the fasting first. As far as the insulin dosage is concerned, whether we can co-administer with the other anti-diabetic agents? Yes, obviously yes, we can. Okay, so what we were discussing, initiate with 10 units, administer with any major meal, or rather with most carbohydrate heavy meal of the day or most meal associated with highest excursion. Whether we can use it twice a day? Well, if the patient is taking 2 large meals, we can inject it twice a day also. So once a day is good, but even twice a day can also be suggested in selected group of patients. But typically I use it once a day. Second meal, I generally choose another insulin, or if patient has difficulty in understanding, then better use same insulin twice a day. How to adjust or titrate the dose? If the fasting is above target, that is more than 120 for X individual, the target has to be individualized, of course. So if the fasting is above target, you increase the dose by 2 units. If fasting is at target, maintain that dose. If fasting is below target, so below 100 say, then you reduce the dose. If you are giving twice a day, then you adjust the dose of Hydagas. The morning dose you adjust based upon the pre-dinner values. The evening dose you adjust based upon the pre-breakfast or the fasting values. How do you intensify? Suppose you started with Rhizodec once a day, 10 units, you have titrated to 20 units. And now your readings are fasting is 100, postprandial lunch is 160, let's say 180, and postprandial dinner, where you are giving this injection, is 150. So you still need to control the postprandial lunch. So you have an option of adding a short-acting insulin or rapid-acting insulin before lunch. If that is not sufficient, you can switch the patient to twice a day Rhizodec, or you can move to the basal-bolus therapy also. Whether we can co-administer other antidiabetic medications? Yes, absolutely. All other antidiabetic medications we can administer along with Hydagas, as is true with all other insulins also. When to intensify? So classically, when fasting is normal now with Rhizodec and the postprandial remains high, you need to intensify either with GLP-1 or with another insulin, that is a short-acting insulin. Or sometimes you have to go to the full-blown basal-bolus kind of therapy. Suppose the patient is on basal insulin once a day, how do you switch? You can start with Hydagas once a day. Suppose the patient is on premix twice a day or once a day, you can switch to Hydagas once a day. If patient is on twice a day premix, you have choice of once a day Rhizodec or twice a day Rhizodec also. If patient is on twice a day basal or twice a day premix, again once or twice a day Hydagas. If patient is on basal-bolus, that still is the best kind of therapy for most of the insulin deficient patients. You have option of 2 Rhizodecs and 1 short-acting insulin at lunchtime, or you can even have 1 Rhizodec and 2 short-acting insulins. But still, having said that, basal-bolus still remains one of the best options. So switching needs to be individualized based on the careful consideration of basal-bolus doses, and close blood glucose monitoring or CGM may be required for aggressive control, at the same time preventing hypoglycemia. The other anti-diabetic agents, whether we can use them, SGLT2 definitely can be used. Sulfonylurea, if you want to continue, which is usually the case in our Indian scenario, then at least cut down the dose of sulfonylurea. Say if you are giving 4 mg of glimepiride, come down to 2. Metformin we can continue. GLP-1, if patient already is on Hydagas and you are starting a GLP-1, then make sure that you cut down the dose of Hydagas so that there is no hypoglycemia after addition of GLP-1. GLP-1 in addition to insulin, the combination is very, very friendly because GLP-1 will prevent the weight gain that is associated with insulin. It will also have better postprandial control. It will also reduce the risk of hypoglycemia by cutting down the insulin dose. So GLP plus insulin is a very good combination, whether you're using individually or as a fixed drug combination. But this forms the best way to treat diabetes with insulin deficiency. I'm not talking about type 1 diabetic patients, I am talking about type 2 diabetic patients having oral antidiabetic agent failure. Metformin, DPP-4, AGIs can very well continue and without any dosage alteration when you are using Hydagas. We have 2 different devices available to inject Hydagas. One is the Flex Touch or the disposable insulin pen. There is no push button extension here. There is unique injection mechanism. Very low dose force is required. So it is the best thing to be initiated. There is end of dose click, so the patient will come to know that the dosage has ended, and is accurate and consistent dosing with this Flex Touch. That is one of the best pens that is available in the market to inject any insulin. On the other hand, if the patient is on long-term insulin, then you have an option of NovoPen 4, which we know is a very durable insulin pen. It delivers the dosage more than 5 years, and there are studies to support that. We have rarely seen in our practice that no pen getting broken or being damaged or not functioning properly. With all other insulin pens, this is possible, but with no pen, it is not so common. There is low dose force required to inject. The dosage adjustment is easy. There are easy to read dose scales here and quick and simple to use this type of pens. So having said that, I would like to summarize that we Indians eat a lot of carbohydrates, and that is why we have high postprandial glucose values in our type 2 diabetic patients. We need a 2-in-1 solution which will take care of fasting as well as postprandial, and iDiGasp is really a simple and convenient solution which offers total control on fasting and postprandial. So when you need to initiate insulin or when you need to intensify the therapy, iDiGasp provides the best solution. In the randomized control trials, meta-analysis, real-world studies, as well as in our own clinical experience, the efficacy and safety of Ryzodeg or iDiGasp makes it a prudent option in the Indian setting. With this, I would like to stop here. If there are any questions, comments, suggestions, we can discuss them.
Can it be given in pregnancy? How to calculate the dose to be given? Is it to be given at night only? And is it available in India? So I feel there are 4 questions to this one
Okay.
question.
Okay.
Can
I'll answer one by one. Whether
yes.
it is available in India? Yes, Dr. Hasina, it is available for last 5-7 years, and we have been regularly using this. Can it be given at night only? No, it can be given before any major meal. So maybe breakfast, maybe lunch, maybe dinner, as I discussed in this presentation, that with highest carbohydrate loaded meal you should give, or in the meal with highest glucose oxygen. Suppose your fasting is 150, postprandial breakfast is 210, postprandial lunch is 230, then you use it before lunch, like that. Whether how to calculate the dose, you start with 10 units and then up titrate the dose, that is the key. And if you had asked me this question 15 days back, my answer would have been no. But now, recently, the degludec component, that is iDiGasp's long-acting component, has got approval for pregnancy in India also. And aspart already has an approval, so definitely you can use iDiGasp in pregnancy also. So it's a news which has just come, maybe a week or 2 weeks before. So you can use it in pregnancy also.
Is any dose equivalence of 30/70 premix and iDiGasp?
Yes. So if you are already using 30/70, say Mixtard or Novomix, if you are using it 20 units per day, you can straight away start 1:1 switch, that is 20 units of Ryzodeg. But generally in practice, what we do, we cut down the dose by 10 to 20%. So if patient is on Mixtard 20, we start with 16 of Ryzodeg. Not that this insulin is more effective. Sometimes we see that the patient with the first dose after change, if they develop hypoglycemia, they start feeling insulin mujhe nahi lena hai. So it is better to start with 10% lower dose, and then always you can up titrate the dose. But usually otherwise the switch can be 1:1. Same dose.
What is the frequency used for iDiGasp? Is it once daily or more than that?
Yes. Again, it's a very good question. Typically, it is once a day because you are taking care of one postprandial with that fast-acting component, and the long-acting component is going to take care for 24 hours. So that is why once a day also would suffice. If you have one postprandial high, it is sufficient. But if you have 2 postprandials which are high, you have to use it twice a day, or you can use it once a day iDiGasp and once a day short-acting another insulin. So typically once a day, but it can be used twice or even sometimes Thrice also. Thrice I have never used. Highest is twice.
Okay, sir. Uh, the next question is by Dr. What is the maximum dose titrated? That's the question.
Well, for insulin, any insulin, the sky is the limit as far as the dose is concerned. But generally, whenever the dose exceeds 40 units at a time, you need to split it into two. So if you want 60 units to be given, do not give it in a single injection, give it in two divided doses. But otherwise, some patients require 80 units also, some patients require 100 units also, which we give in divided doses. Because as I said, more than 40 units at a time does not serve the purpose.
Yes, thank you so much, sir. The next question is by Dr. In DKD patients.
Well, in DKD patients, Idigas can be safely used. The fast-acting component will take care of the postprandial. In degludec, because in CKD the risk of hypoglycemia is higher, degludec has lower risk of hypoglycemia, and that is why it's the preferred insulin. So for DKD patients also, one can use Idigas.
Thank you, sir. The next question is the interval between meal and the insulin. When can be given before? When can it be given before or after the meal?
Yes. So classically, 10 to 15 minutes before meal. But even if injected just 5 minutes before meal, it will also lead to very good postprandial glucose control. In some patients, not all, in some patients where how much amount of food the person will eat is not certain, there you can inject it after meals also. But otherwise, for after meal, FIAS, that is fast acting aspart, has better data compared to any other insulins. So this insulin is typically given 10 to 15 minutes before meal or just 5 minutes before. Usually in practice, what happens? Patients immediately eat, which may be okay with this insulin, but not with the older insulins like Mixta.
Thank you, sir. What will be the starting dose for Idigas for an obese patient?
Obese or non-obese, once you decide to start, do not initiate with more than 10 units. That is the standard recommended dose for initiation for Idigas, 10 units. If you are starting for a pediatric patient, the dose may be even lower, maybe just 4 units, or you can say 0.1 unit per kilogram. But otherwise, one should start with not more than 10 units. However high the weight is, however high the sugar is, starting dose in adult should be 10 units.
Okay, sir. Thank you, sir. The next question is asking Idigas insulin, if given once daily, will it control the postprandial glucose at other meal times?
It's a very good question. My answer to that is no, it will not control the postprandial glucose at other meal times. If you are giving it before dinner, it will control the post dinner and the fasting values, but not the post lunch or post breakfast values. Yes, by bringing down the fasting, the post lunch and post breakfast values also will come down to some extent, but not to a great extent. So yes, if all the postprandials are high and fasting is not that high, then you need to choose some other therapy, not this insulin, or you need to use it at least twice a day. So it's a very good question.
Or so can we give like the short acting insulin postprandially along with it? Can
Correct,
that be
correct.
possible?
So the different combinations, Rhizodec twice a day and aspart once a day, or Rhizodec once a day and aspart twice a day. So different combination permutations can be possible for such patients.
Okay, sir. Thank you so much, sir. Next question is by
4 into body weight,
body
no.
weight,
We
SKR.
generally start with zero point 0.1 to zero point 0.2 unit per body weight. That is okay for glargine or for 2-0. But for Rhizodec and Tresiba, we start with 10 units. Yes, in pediatric age group, 0.1 to zero point 0.2 units to start with. So usually 0.1 units. So if the child is weighing 30 kg, we start with just 3 or 6 units, not more than that. 0.1 to 0.2.
Thank you so much, sir.